Thanks, Dr. Landsman, and thanks, Dr. Greep and the rest of the committee for the invitation. My topic is management of type B aortic dissection. We're going to stick to acute type B dissection in the interest of time. As you're all aware, acute type B dissection involves the aorta distal to the left subclavian artery, represents anywhere from 25 to 40% of all acute dissections. Type B dissections are divided into uncomplicated and complicated disease. Complicated disease generally refers to the presence of rupture, malperfusion, or refractory pain or hypertension, and has traditionally been treated by open surgery or now endovascular management, whereas uncomplicated disease, which is 80 to 85% of type B dissections, medical therapy has been preferred. The history of the treatment of this disease dates back to the Duke-Stanford series published in Circulation in 1990, which examined examined type B dissection patients and found that in the uncomplicated patients there was no difference in outcome for medical management versus surgery, and confirmed medical management as the preferred initial treatment strategy for these uncomplicated patients, with surgery reserved for those with complications. This is the original IRAD data, which demonstrated 11% mortality for medically treated type B dissection patients. More recent data from Sweden demonstrated no mortality in 66 uncomplicated patients who had 100% survival at 1 year, and follow-up survival demonstrated that to be similar to an age and gender-matched Swedish population, and they concluded that excellent results with medical management of uncomplicated type B dissection. Based on data such as these, the STS Endovascular Task Force said that in patients with uncomplicated acute type B aortic dissection, medical management constitutes a benchmark that will be difficult to surpass or even match by endovascular stent graft treatment. And they gave uncomplicated dissection a 2B, meaning that the efficacy is not established for the use of TEVAR for this indication. There are some limitations of medical management. If you look at follow-up data, this is IRAD data on 242 patients discharged alive after hospitalization for acute type B dissection. The 3-year survival is only 78%. Admittedly, a significant number of these deaths are due to comorbid conditions, but multiple studies have demonstrated that at least 25%, maybe up to 50% of medically treated patients will develop late aortic-related complications, generally due to aneurysmal degeneration of the false lumen. This is a study from Japan that looked at this. 62 patients with uncomplicated dissections followed up for 49 months. 84% of the patients had an increase in aortic size during follow-up, with the upper thoracic aorta being the major site of late aneurysmal degeneration. Presence of blood flow in the false lumen during follow-up was the only significant risk factor for a late increase in aortic size. So if a patent false lumen is bad, and multiple other studies have shown that a completely thrombosed false lumen is good, one might theorize that placement of a stent graft across the primary tear would result in false lumen thrombosis, enhance aortic remodeling, and prevent these late aortic problems. But this promise of TEVAR is really yet to be realized, at least in all patients. The INSTEAD study tried to look at this, took 140 uncomplicated patients and randomized 72 to TEVAR and 68 to optical medical management. They were subacute dissections. The patients were randomized anywhere from 2 weeks to 52 weeks post-event. The only positive result of the study was that aortic remodeling, defined as true lumen recovery with false lumen thrombosis, was significantly higher in the TEVAR versus the medically treated group, but there was no difference in all-cause mortality as demonstrated here. Further, there was no difference in aortic-related disease. The INSTEAD trial has several limitations. It obviously randomized low-risk, uncomplicated patients. By definition, the patients had to survive 2 weeks prior to randomization, and thus the possibility exists that the higher-risk uncomplicated patients either died or were treated with TEVAR or surgery in the initial 2 weeks post-dissection, and so were not eligible for the trial. The trial had small numbers. It was underpowered. There was a high rate of aorta-related deaths in the TEVAR group, 6%, which was twice that in the medical management group, and they were mainly technical periprocedural complications such as access vessel rupture, retrograde type A dissection, and thoracic rupture despite TEVAR. And likely many of these complications are related to the fact that there was a short length of aortic pavement, less than 15 centimeters in most patients, and they're also using the earlier generation Medtronic Talent device, which was not the appropriate device for this kind of application. Further, medical management was good, but still 2/3 of the deaths in the medical management group were due to rupture, and the duration of follow-up of only 2 years is short, and basically it's not the final answer to the question. but it does beg the question, is there a subset of high-risk, uncomplicated patients who might benefit from early TEVAR? Going back to the Swedish study that I showed you earlier, about a third of the patients developed an aortic-related event by 10 years, and the significant predictors of an aortic event were maximal diameter greater than 4 centimeters on the initial CT scan or the presence of an intramural hematoma with a localized penetrating ulcer. This study from Marui from Japan looked at 141 uncomplicated type B dissection patients and found that a maximal aortic diameter of 4 centimeters or greater with a patent false lumen predicted late aortic events, and patients with these features had only an 8% freedom from late aortic event at 10 years, and they recommended early intervention for patients with these predictors. Paper by Song et al. From South Korea of 100 patients with aortic dissection involving the descending aorta who were followed for 53 months. About a third of them developed a 6-centimeter or larger aneurysm during this follow-up period. The aneurysms were most common in the proximal descending thoracic aorta due to dilatation of the false lumen. And they found that the initial false lumen diameter at the upper thoracic aorta, as shown here, was the single most powerful predictor of late aneurysmal change. It was more powerful than initial aortic diameter. Patients who had a greater than 22 millimeter false lumen diameter at the upper thoracic aorta had significantly faster rates of aortic dilatation and a higher incidence of aneurysmal change. Further, they had a significantly lower event-free survival, as shown in the graph, and they concluded that early TEVAR may be considered for patients with large, that is 22 millimeter or greater initial false lumen diameter in the upper thoracic aorta. Another study looking at 170 patients with acute type B intramural hematoma found short-term mortality was minimal, but over a 7-year follow-up period, about a third of the patients developed a new penetrating ulcer. These were all seen within 30 days of the initial IMH, and they were most common, as shown in the figure, in the proximal descending thoracic aorta. And the patients with a new penetrating ulcer had significantly poorer long-term survival as compared to those who did not develop a penetrating ulcer. This was related to the fact that the patients with new ulcers had significantly poorer aorta-related event-free survival, as shown in the graph. A third of the patients with penetrating ulcers developed adverse aorta-related events, and if the penetrating ulcer was in the proximal descending thoracic aorta, 60% developed an adverse event. The predictors of adverse late aortic-related events were maximal aortic diameter and the development of a penetrating ulcer in the proximal descending thoracic aorta. And similar to the other studies, the authors concluded that early TEVAR should be considered in type B IMH patients developing a penetrating ulcer in the proximal descending thoracic aorta. Finally, what about this refractory pain or refractory hypertension? Does this really represent a high-risk scenario in an otherwise uncomplicated patient? IRAD looked at this in 365 patients, 69 of whom had recurrent or refractory pain or hypertension. The remainder did not, and they found that the in-hospital mortality was significantly increased in the refractory pain or hypertension group, and that increased mortality was generally due to the fact that if you look at the results with medical management for patients with refractory pain or hypertension, it's significantly higher at 36%, versus if they didn't have pain or hypertension, they had only a 1.5% mortality with medical management. And 2/3 of these deaths in the refractory pain or hypertension group treated medically were due to rupture. By multiple logistic regression, they found that recurrent or refractory pain or hypertension was an independent predictor of in-hospital mortality, and the IRAD group concluded that TEVAR may be indicated for refractory pain or hypertension, as it's clearly associated with improved outcomes over medical management. So just to summarize with regards to uncomplicated but high-risk type B, uncertainty remains regarding the optimal management of these patients, but consideration of early TEVAR appears reasonable in the scenario of a 4-centimeter or greater initial aortic diameter with a patent false lumen, with a 22 millimeter greater false lumen in the proximal descending thoracic aorta, with intramural hematoma with penetrating ulcer in the proximal descending thoracic aorta, and in the setting of recurrent or refractory pain or hypertension. But the final answer to this question awaits a well-designed prospective randomized controlled trial. This is just an example to show the importance of medical compliances. One of our patients who presented with a type B dissection, a young guy who history of medical noncompliance. You can see he had no high-risk features. The aorta was less than 4 centimeters. His initial false lumen diameter was only 15 millimeters. He was managed medically. He did okay. At his 1-month visit, you can see his aortic diameters are stable. His blood pressure was still poorly controlled at that time, and it was suspected he was not taking his medications. He then failed to come back for any more follow-up visits and showed up 16 months later when he was readmitted with a hypertensive urgency. And you can see that he's developed this thoracoabdominal aneurysm with his aorta enlarging by 2 centimeters in a period of only 16 months, and he subsequently underwent successful open extent 1 repair. Moving on to complicated dissection, this is an example of a rupture patient that we treated with TVAR. She was elderly and on HOMO 2. The other complicated scenario is a malperfusion, which can be divided into dynamic and static malperfusion. In dynamic malperfusion, the pressurized false lumen leads to occlusion or narrowing of the branch vessels by the dissection membrane. Here's an example of a dynamic occlusion of the celiac, whereas in static, the dissection extends out into the branch vessel, and the branch vessel subsequently thromboses distal to that. This is an example of an SMA that's dissected and thrombosed distally. This is a more challenging clinical problem. Dynamic malperfusion is generally relieved by covering the primary tear. On occasion, you may need to place additional stents distally, stents or stent graft, whereas static malperfusion, if reperfuse the true lumen, it's not going to necessarily relieve this problem and may require branch vessel stenting or bypasses of the involved arteries, but it's a much more difficult problem. We use IVUS. We use TE on all TVAR cases, and we use IVUS on all dissection cases. We think it better confirms that you're in the true lumen. It also helps identify the primary tear and distal fenestrations. And at the end of the case, along with TE, can be used to assess the ascending aorta, rule out a retrograde type A dissection, which we know is a risk. When you're doing these cases, you need to keep in mind what your goals are. In a malperfusion case, your main goal is to cover the primary tear and reestablish distal flow, but if you have an endoleak, it's not necessarily a problem. Whereas in rupture, you have to cover the primary tear, all distal fenestrations, you can have no endoleak. And the problem with these rupture cases, it's often difficult to tell where the aorta was leaking or is leaking, and thus you frequently need to pave the entire thoracic aorta. So why not open repair? Well, this is IRAD data, again, demonstrating 29% in-hospital mortality, 23% neurologic morbidity, 18% renal failure, whereas with TVAR, this is a meta-analysis from a couple years ago, 29 studies showing 9% in-hospital mortality, 8% morbidity, 2% retrograde type A dissection. And really, at this point, there's little to no debate in the literature for TVAR versus open surgery for acute complicated type B dissection. This is still investigational in the United States. There are several clinical trials which are either completed or ongoing. The CTAG trial is complete. The Valiant trial, I think there's 4 patients left to go. We enrolled one yesterday. And the Cook Zenith trial is just beginning, so it's likely within a year or so this will be an approved indication for the complicated patients. The connective tissue patients that present with acute complicated dissection, I think that we typically don't do stent grafting in connective tissue patients, but this may be one scenario where, at least in the acute complicated patient, that TVAR could be considered, although I would consider it generally as a bridge to likely late open repair. One reason why we don't do TVAR in all type B dissection patients is this problem. This was the initial report from the European registry, which highlighted this problem. You can see more than 75% of the retrograde type A dissections occurred in patients who were undergoing endografting for a dissection indication. We recently published our data in over 300 TVAR cases about a year or so ago, and we found that this complication occurred only with arch landing zones. Dissection was definitely a risk factor. Dissection indication was definitely a risk factor for retrograde type A, as was a ascending aortic diameter of 4 centimeters or greater, as well as zone 0 proximal landing zone, similar to what we were hearing yesterday in the hybrid arch discussions. Combinations of these risk factors conferred even greater risk, and we recommended that completion TE or IVUS assessment of the ascending aorta is mandatory if you're doing arch landing zones, and then immediate CT surgeon availability should be present in any institution that is doing TVAR. So finally, these patients, as I mentioned, a lot of them will develop late aortic problems. They need lifelong aortic surveillance. Historically, beta blockade has been the cornerstone of medical therapy, although there's recent IRAD data that suggests for uncomplicated type B dissection patients that the calcium channel blockers actually have a survival advantage, and that needs to be investigated further, but something to consider. The patients all need serial imaging and followed by an aortic specialist. And to close, just to summarize, medical management remains the preferred treatment strategy for uncomplicated type B dissection patients, but as I showed you, medical compliance is critical. TVAR is clearly the treatment of choice at present for acute complicated dissections with rupture or malperfusion. There's a potential role for TVAR in high-risk uncomplicated patients, but this requires further study, and the patients require close lifelong follow-up. Thank you.